to be a physician assistant, or nurse practitioner, we feel like this pharmacology course is the right course for you. So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome. Welcome back to the Doctors in Training Pharmacology Review course. In this lecture, we're going to be discussing medications used to treat disorders of the respiratory system, disorders like asthma, COPD, and allergic rhinitis. There should be a corresponding chapter in whatever pharmacology text you're using. If you're using Lippincott's Pharmacology, the 4th edition, this lecture corresponds to chapter 27. We are happy today to have Dr. Angie Moore as our primary lecturer. She is a board-certified pediatrician, and you'll be seeing me again intermittently throughout this lecture to review some of the key points and add in some additional high-yield information. So without further ado, Dr. Angie Moore.
Hello and welcome to Respiratory Pharmacology, Chapter 27. My name is Angie Moore. I'm a pediatrician in private practice, and I'll be talking to you today about respiratory medications in the context of 3 diseases: asthma, COPD, chronic obstructive pulmonary disease, and allergic rhinitis. And we'll start off by talking about asthma. Asthma is a very common medical problem. You're going to run across a lot in practice. There's a definite genetic component to asthma. You'll see it running in families, and there's also an allergic component as well. When we talk about treatment of asthma, the first thing you'll tell your patients is avoid the triggers of their asthma. Common triggers would be smoke. So, your patient who has asthma should not smoke and shouldn't be around someone that smokes. They may be allergic to certain types of pets, that sort of thing. Unfortunately, it's impossible to avoid the most common trigger of asthma, which are viral upper respiratory infections, cold viruses. If I told the parents of a 5-year-old patient with asthma, your child's asthma will be fine as long as you don't let them get a cold, that would be virtually impossible for them to carry out. It'd be like telling the teenager that they have to stop texting on their phone. It's not going to happen. So if we can't avoid the triggers, then we need to talk about treatment for asthma. As you probably already know, asthma has 2 components, and this is really important to remember. If you look at the diagram showing a normal lung tissue and then a cross-section of asthmatic tissue, you'll notice that the normal lung, the smooth muscle in the wall is nice and thin, the airway is nice and open. And then you move down to the asthmatic lung, and you see the thickened smooth muscle, lots of mucus and inflammation inside the airway. And those are the 2 components of asthma. Asthma is a chronic inflammatory disease in the lung that causes episodes of bronchoconstriction. So it's inflammation and bronchoconstriction. And if you can know those 2 components of asthma, that's going to get you a long way into understanding how to treat asthma. When we talk about treatment of asthma, what I really want you to remember are the frontline medications. There's 2 medication types that you really need to know, and they treat those 2 components of asthma. So for inflammation, it's our good friend the corticosteroids, and for bronchoconstriction, the beta-2 agonists like albuterol. And I'm going to go through both types of both of those medications along with some other treatments for asthma. But first, I want to talk a little bit about the diagnosis of asthma. We all like to have a test we can order and say, oh, this test came back, that's what they have. But asthma is not like that. Asthma is a clinical diagnosis. And so you have to base your diagnosis on the symptoms that your patient has. I would be willing to bet also that when I say asthma, the symptom that comes to your head is wheezing. And while it's true that asthmatics do wheeze, I'd like to change that paradigm a little bit. When you hear asthma, I want you to think cough. Cough is the symptom that you're going to ask about to decide whether or not your patient has asthma, whether or not they're on the right medications, and whether you need to change anything. So when you hear asthma, I want you to think cough. It's interesting because my patients will often come in, either the parent will say or the child will say, I've been wheezing. And I always think, well, they may have heard wheezing from the lungs without a stethoscope. That's unusual and usually is a pretty severe asthma exacerbation. Most of the time, when you question them and you ask them, okay, you're wheezing, what does that mean? They actually have learned to call it wheezing when they're having these other symptoms, when they're coughing, having chest tightness, or shortness of breath. And so, again, I want to just make sure you have in your mind, when you hear asthma, I want you to think cough. And there certainly are some confirmatory tests you can use for asthma, even though it is a clinical diagnosis. And this is in your study guide. It'll ask, how do you confirm asthma? And you can do that with spirometry and pulmonary function tests, or PFTs. You have to have a cooperative patient for that. So, for my patients that are under the age of 5 to 7, they're probably not going to be able to do spirometry, and so I have to rely on a clinical diagnosis. Before we go fully into all the medications, I want to talk a little bit about what our goals of therapy should be, and this is in your study guide as well. We have 2 goals for therapy. The first is to reduce impairment, and what do I mean by that? I mean, I want my asthmatic patient to have the same quality of life as my non-asthmatic patients. And so I want to reduce their chronic symptoms and also reduce their use of rescue medications. And I want them to keep their normal activities. If they want to play soccer, they should go play soccer. If they're not able to because they're coughing or having more symptoms of their asthma and they're sidelined because of that, I tell them I want them to come back. We need to change their medications. We need to optimize that. So we want to reduce impairment. And then I also want to reduce risk. Fortunately, for most asthmatics, their disease is not progressive. So what do I mean by that? I mean, if you have a patient who's 45 that has had asthma for 40 years, their lung functions at 45 are probably very similar to what they were at age 5. So that's good news for your asthmatic. It's not a progressive disease, but it is a chronic disease. And so as with any chronic disease, I want to try to balance out their treatment with side effects. So I want to make sure that we're on optimum treatment with as few side effects as possible. And then also I want to reduce the number of visits they have to emergency rooms and certainly hospitalizations. That's the main goal with reducing risk. Hospitals are places for sick people, and we don't want our asthmatics to actually be sick. We want them to be able to be treated at home. So we want to reduce impairment and reduce risk. All right, so that brings me to the infamous or famous, probably more infamous, asthma classification table. And I'm going to refer back to this several times in the talk. And I will be perfectly honest, I've probably memorized this table at least 5 times in training, several times in med school, several times in residency, and it never really stuck until I could kind of break it apart and figure out what it was trying to tell me and tie it to clinical work. And so hopefully as we go through and kind of break up that table, I can help you to understand it and remember it as opposed to just memorizing boxes on a table, which you can also do, but is not going to really be useful to you in the future. So as we look at that asthma classification table, you're going to notice on the left-hand column, you'll see the different types of asthma. So we have mild, intermittent, and then mild to severe persistent asthma. What I really want to direct you to at this point, as we move on to talk about treatment of asthma, is the far right column. And that far right column shows that all types of asthmatics need to have access to a short-acting beta-2 agonist. So when we talk about beta-2 agonists, they work as bronchodilators. It's a selective medication. It goes to the beta-2 receptors in the lungs, although you can get systemic symptoms from the medication. The most common of these are some muscle tremors and increased heart rate. The short-acting medications, they last typically the effect is for a few hours, but the onset is very quick. So that they take the medication and within minutes they're feeling better, and that symptom relief typically lasts for a few hours. So again, as you can see on that table, all asthmatics, regardless of what type they have, should have access to that short-acting beta-2 agonist inhaler. And if I'm talking about short-acting ones, there's probably long-acting as well, and that's true. We'll move on to the long-acting beta-2 agonist. And the example of that you'll see most frequently is salmeterol. These medications are long-acting because they have a lipophilic component that binds to the cell membrane and allows for slow release into the airway. And the effect is usually 12 hours, can be up to 24 hours. So depending on how your individual patient is affected by the medication, they may be able to take it once or twice daily to get effect. So going back to the asthma classification table, I want you to think about who would need a daily long-acting beta-2 agonist. If they're having daily symptoms of asthma where they're needing to use their rescue inhaler on a daily basis, those are the patients that you want to add in a long-acting beta-2 agonist. That way they can hopefully stop using that short-acting inhaler, their rescue inhaler, as frequently. So when you look at the table, the daily symptoms of asthma, that corresponds with being a moderate or severe persistent asthmatic. So those are the patients that will need to be on a long-acting beta-2 agonist. One thing I want you to just note in your study guide on the side effect, probably on side effects of the long-acting beta-2 agonist, is just to know that there are phenotypic differences between people in the response to the beta-2 agonist. And this will come up actually probably more often on a test than in real life, but there is a site on the beta receptor in the lung that for those patients who are homozygous for arginine, they will have increased risk of having worsening symptoms when you start a long-acting beta-2 agonist. That actually represents about 20% of the population. So when you start this medication, you want to say to your patients, I expect that this will help you. I think that this is going to reduce your need for your short-acting rescue inhaler. But if your symptoms get worse, I need you to call me. I need you to stop the medication, and we'll talk about other treatments that we can add in. So it's important to know that there are phenotypic differences. Obviously, your patient is not going to know what their phenotype is. It's not possible to do the testing in a clinic situation, but you should know that there's differences there based on phenotype. Okay, so that brings us to our next group of medications. So we've talked about the beta-2 agonists, both short-acting and long-acting, and which patients need to be on those medications. And now I'd like to talk about corticosteroid use. And as I've mentioned before, asthma has the two components, and that inflammatory component of asthma is largely related to cytokine release. So in the asthmatic, their airway is more sensitive to certain triggers, like we've already talked about, and is more reactive. So a cold virus than in a non-asthmatic, they would cough and sneeze and have fever for a few days and then get better. In an asthmatic, they cough and cough and cough, because the more they cough, the more inflammation they get in their lungs, and then the more they cough. So the corticosteroid medicine is used to break that cycle and decrease inflammation. The corticosteroids also can have an effect on the smooth muscle. They don't cause bronchodilation, but they can make that smooth muscle less reactive, so that the next time the patient is exposed to a trigger for their asthma, the muscle is not as likely to bronchoconstrict. And so the corticosteroid actually has an effect on both the inflammation and bronchoconstriction. The bronchoconstriction part is a little more indirect. As we talk about corticosteroid use, there's two different types. One is an inhaled corticosteroid. So this is basically a topical medication, just like you'd put a steroid cream on a rash. This is a inhaled corticosteroid that goes where you need it, in the lungs. And then you can also use steroids in a systemic fashion, so orally or through an IV, particularly when they're having an asthma exacerbation or acute difficulties with their asthma. As we talk about the inhaled corticosteroids, I want to take you back again to that asthma classification table and point out that when you think of inhaled steroids, I want you to think of them as a preventative medicine, and that preventative medicine is needed for all persistent asthmatics. So on that table, whether it's mild, moderate, or severe persistent asthma, all patients with persistent asthma need to be on a preventative medicine, and that preventative medicine is an inhaled corticosteroid. So that's the last component of that table. If you can understand which patients need the steroid medicines, which ones need the long-acting beta-2 agonists, and that all patients need the short-acting beta-2 agonists, you understand that table, and hopefully it'll stay in your mind a little bit longer. One thing I wanted to point out about the systemic use of steroids, which we try to avoid in asthmatics unless they really need it. So they're getting daily medications potentially of an inhaled corticosteroid. But if a patient has an acute exacerbation, meaning they were doing fine, they get a cold, and suddenly they're having trouble breathing, they're really working hard to breathe, they're having a lot of cough, they come to see you in that situation, they're probably going to need an oral or IV steroid medication in order to recover. One other note about the inhaled corticosteroids is if they've been treated in the past like an intermittent asthmatic, meaning they just have a rescue inhaler and no daily medication, and they suddenly come to you acutely ill from their asthma, it's not going to do much good to start an inhaled corticosteroid at that point and expect it to have a curative effect or for them to improve on that. They're going to need an oral steroid medicine and then potentially starting the inhaled corticosteroid once they're done with the oral steroid. One other point that's in your study guide is talking about spacer use, and that's for all types of inhalers, whether it's a steroid medicine or it's the beta-2 agonist medication. If a patient is using an inhaler, they really do need to use a spacer. And there's we'll show you a diagram, but basically what this is it's a tube that you squirt the puff of inhaler medication into, and it allows the medication to distribute within that tube so that when the patient breathes it in, it actually goes down into their lungs, as opposed to puffing the inhaler in their mouth where 90% or so of the medication will stay in their mouth. And so I always want my patients to use a spacer with an inhaler, and certainly young children and elderly people should definitely use a spacer because there's coordination involved in that the spacer really helps with. And just one other note about the steroid medication as far as side effects, there's actually, for the inhaled corticosteroids, very few side effects. Long term, kids who have their asthma well controlled with an inhaled corticosteroid have the same growth and development patterns as their non-asthmatic counterparts. In fact, they're more likely to reach a normal adult height than an asthmatic who has been poorly controlled or not been controlled well with a steroid medication. And then the other side effect for the inhaled steroids that you definitely should know about is oral candidiasis, oral thrush, and that's a consequence of having that steroid medication stick in the mouth and then they end up with thrush. That can be avoided. It can be avoided by having your patient swish water in their mouth and then spit it out after they've taken their medicine, or in younger patients that can't swish and spit, brushing their teeth afterwards, and then it's treated with medication to treat the thrush.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
Goodbye, darling. Have a good day. Poor Bill. He was up all night. We think that he might have asthma. And do you know the most common symptom of asthma? That's right, a cough, along with recurrent wheezing, difficulty breathing when exercising, and recurrent chest tightness. And what are the two components of an asthma attack? Inflammation and bronchoconstriction. I hope he'll be okay. We just need to stay strong and remember that all that wheezes is not asthma.
Quick review 1. So let's review some of the key points from Dr. Moore's lecture by going through your study guide and making sure you have everything filled out. So if you look at page 1 of your study guide, number 1, what are the two components of an asthma attack? You got inflammation, you got bronchoconstriction. Those are the two main components. Number 2, how is asthma diagnosed? She talked about how it's a clinical diagnosis with respiratory symptoms. And a very important feature of the diagnosis of asthma that distinguishes it from COPD is that asthma is reversible. You can treat it. You have airway obstruction, and then when you give your adrenergic agonist, the airway obstruction is somewhat relieved. So it's reversible airway obstruction, or in other words, variable expiratory outflow obstruction. COPD is not so reversible. Number 3, what is the most common symptom of asthma? Dr. Moore mentioned that it was cough. Number 4, what tool can help confirm the diagnosis of asthma? That's a spirometer. So spirometers are very useful tools in treating asthma and in diagnosing asthma. It's a measure of, you can use a spirometer, have the patient forcibly exhale into the spirometer, and it's going to measure the FEV1, the forced expiratory volume of 1 second is what FEV1 is. And the spirometer can measure that. If it's very low, it could be because you have airway obstruction. So if it's low and you give some adrenergic agonists like albuterol, and then your spirometer shows that your FEV1 increases and improves, then that would be diagnostic of asthma. Number 5, what are the goals of asthma treatment? We talked about reducing risk so that you don't have an asthma attack and need to be intubated at some point. And the second goal is reducing impairment. You want these individuals to have normal lives. The next one, number 6, what are the 2 main drug categories used to treat the main components of asthma? So for your bronchoconstriction component, you're going to use your adrenergic agonists. And then for your inflammation component, you're going to use corticosteroids. Number 7, the classifications of asthma. Just to briefly review these again, your classification, if it's intermittent asthma and you have symptoms such as cough or wheezing occurring less often than once a week, it occurs intermittently, that's mild intermittent. The next category moves on to persistent. If it occurs at least every week, that's persistent. All right, it's not really going away. So you have mild persistent, moderate persistent, severe persistent, and Dr. Moore did a great job explaining the treatment for these. The rescue relief, for all of these categories, they have to have an inhaler available to them so that when they do have an asthma attack, they can get to their inhaler and they can relieve their symptoms as best they can immediately. If their inhaler doesn't work, they may need to come in to receive a nebulized albuterol or levalbuterol treatment. Now, when do we introduce low-dose inhaled corticosteroids? That's with mild persistent. And then with moderate persistent, you can increase the dose of the inhaled corticosteroids. You might add a long-acting beta-2 agonist. But what are you going to do if that long-acting beta-2 agonist makes your symptoms worse? You're going to stop it, right? Because maybe you have that genetic mutation that makes, with which long-acting beta-2 agonists make your symptoms worse. And then with severe persistent, if it's severe, you're going to need high-dose inhaled corticosteroids. So any persistent asthma, you need inhaled corticosteroids, either low dose, medium dose, or high dose, and then along with that, your long-acting beta-2 agonists. Now, it doesn't mention in this table what if you have an asthma attack, status asthmaticus. We're going to get to that in a minute. Number 8, complete the following table. Let's make sure you got all these key points in here. So your beta-2 agonists, how do they work? This is albuterol, terbutaline, levalbuterol are your main ones. So albuterol is sort of your go-to drug. It's the most commonly used inhaler in the treatment of asthma. Terbutaline is not inhaled. Terbutaline is given subcutaneous treatment for asthma is how terbutaline is used. And then levalbuterol is a stereoisomer of albuterol, all right, and it has less tachycardia. We'll get to that in a second. So the action of all these drugs, they're beta-2 agonists. So they're stimulating the beta-2 receptor. They are bronchodilators. Potent bronchodilator. They relax airway smooth muscle. When do we use these drugs? So they're used in treating asthma and all of the different categories of asthma. They need to have one of these rescue agents in here. Now, one other thing I'm going to throw in here, can you use inhaled epinephrine in the treatment of asthma? Sure, yeah. It's actually over the counter. It's primatine mist is inhaled epinephrine. And so that can be used, but it's kind of dirty. It's not selective beta-2 agonist. It's, you're going to get beta-1, so you're going to have lots of tachycardia. You're going to have beta-2, which is going to relieve symptoms. You're also going to have alpha-1 stimulation. It's going to raise your blood pressure. So inhaled epinephrine is not the go-to drug in treating asthma, but will it work? Sure, it will work. Adverse effects of your beta-2 agonist, tachycardia is a big one, and like I mentioned before, if you have a heart disease patient that has an asthma attack or has asthma symptoms, you want to give them a beta agonist, but you don't want to raise their heart rate, you would reach for levalbuterol. Levalbuterol has less heart stimulation, less tachycardia than does albuterol. Additionally, these beta-2 agonists can cause some level of hyperglycemia. Beta-2 agonists can also cause hypokalemia, right? And we use this in the treatment of hyperkalemia. So if you have a patient with elevated potassium levels, which is an emergency, high potassium can kill you due to arrhythmias. So if you have a patient with high potassium and you want to lower it very rapidly, one thing you can do is have them inhale some nebulized albuterol. It'll help shift potassium into cells. Beta-2 agonists also can cause some level of hypomagnesemia. It can decrease your magnesium levels. But the main one is tachycardia. Dr. Moore also mentioned a nervousness or muscle tremors or tremulousness. That also goes to stimulation. So sort of stimulating the fight or flight response. Your long-acting beta-2 agonist, salmeterol and formoterol, basically the action is the same as the beta-2 agonist, or stimulating the beta-2 receptor at smooth muscles. Therapeutic use, these are longer acting. All right, so can you use these drugs to acutely treat asthma? Absolutely not. You do not use these drugs to acutely treat asthma. It's highly testable in that fashion. Adverse effects are going to be the same, and like we mentioned before, in some patients the beta-2 agonists can actually worsen symptoms if you have that genetic mutation. Corticosteroids, inhaled corticosteroids, beclomethasone, triamcinolone, budesonide, fluticasone. These are your drugs of choice for persistent asthma. So if you have any patient with persistent asthma, they need to have a prescription for an inhaled corticosteroid, and they need to have an inhaled beta-2 agonist like albuterol available. How do steroids work? They are going to decrease the inflammatory cascade, and just in general, they inhibit phospholipase A2. So you can write that in the action for both the inhaled and the oral systemic. Steroids inhibit phospholipase A2. Phospholipase A2 is at the very top of your inflammatory cascade. So if you want to make leukotrienes, if you want to make cytokines, the way you get to make those starts with cleaving of molecules by way of phospholipase A2. If you inhibit phospholipase A2, you don't get to make cytokines. All right, so there's essentially very little to no inflammation with steroids on board because they're inhibiting phospholipase A2. So the inhaled corticosteroids, the great thing about them is they're localized to the lung tissues, to the airways, versus a systemic or oral or systemic corticosteroids. They go throughout the whole body, so they're going to have a lot more side effects going throughout the whole body. Your inhaled corticosteroids, very minimal side effects. What are the adverse effects of the inhaled corticosteroids? Dr. Moore mentioned you can get oral candidiasis, also called oral thrush, Candida albicans infection of the mouth, the tongue. How do we reduce the incidence of that? If you take your inhaled steroid by using a spacer, a lot of those steroid particles are not going to get deposited in the mouth. Additionally, if you can rinse out your mouth after you use your steroid, you're going to reduce the incidence of thrush. Do most adults get thrush from inhaled steroids? No, not usually, but it can happen. It's more common in younger kids. Side effects of oral systemic steroids. There's a lot of side effects, obviously, with oral or systemic steroids, whether they're given orally or IV, doesn't matter. Lots of side effects. Steroids are potent immunosuppressive drugs, so you're more likely to get infections when you have steroids on board. Steroids cause hyperglycemia. All right, so it's one of your counter-regulatory hormones, glucocorticoids or corticosteroids. So they raise your blood sugar level. Steroids can cause osteoporosis if they're used long-term. Steroids, of course, can cause your Cushing syndrome with the buffalo hump and the moon-shaped face, the abdominal striae, weight gain. Again, they can exacerbate diabetes. They can cause adrenal insufficiency. When you're on steroids for a long period of time, you stop making endogenous steroids. You shut down your body's capacity to make endogenous steroids. So if you abruptly withdraw oral or systemic steroids, you're going to have what's called a tertiary adrenal insufficiency, and you're going to it's very bad news. The other thing with steroids, of course, they can cause acne, they can cause cataracts, lots of different side effects with systemic steroids. Just to highlight a few more of these points, number 9, what are the side effects of the beta-2 agonists? Again, tachycardia, muscle tremors, hypokalemia. You can also have hyperglycemia and hypomagnesemia. Number 10, why should spacers be used when inhaling steroids? Not only is it going to reduce the incidence of oral thrush, it's also going to help smaller particles get into those more terminal airways. All right, so you're going to have better drug penetration into the tissues with your spacer than without. It's also going to reduce symptoms. Number 11, how long does it take for systemic steroid to begin reducing inflammation, and which works more rapidly, oral or intravenous steroid? Whenever you dose a systemic steroid in the treatment of asthma, it takes 4 hours for that drug to start working. You're going to see this a lot in the ER, whether it's the PD ER or the adult ER. Patient comes in with an asthma attack, you give them some albuterol or levalbuterol, you give them a steroid. Do you give them oral steroid or IV steroid? It doesn't matter. They both take 4 hours to start working. You have the patient stick around for about 4 hours until their symptoms are relieved, and then they're either going to get admitted or they're going to go home. But you can't reevaluate a patient for successful treatment until it's been 4 hours after the steroid has been dosed. What are some of these steroids? Just to mention them, it's important you guys hear these drug names so you know how to pronounce them. So your oral systemic steroids, there's a ton of them, but the ones we have listed here are prednisone, prednisolone, triamcinolone, and then methylprednisolone. And of these steroids, the one that's commonly used in the ER to treat asthma is methylprednisolone, also known as Solumedrol as a brand name, but prednisone is fine too. Moving on, number 12, the combination products that include inhaled corticosteroids and long-acting beta-2 agonists. So if you have a moderate persistent or severe persistent asthma and you want that drug combination, instead of having 2 inhalers, you have 1 inhaler with both meds in it. And so those are the drug combinations you have there. Budesonide and formoterol, which is Symbicort, and then fluticasone and salmeterol, which is Advair, which is very common also. Again, if your symptoms worsen with these meds, it's because these patients are not going to respond very well to the long-acting beta-2 agonist. So that's it for this section. Let's pick back up with our lecturer.
Now we move on to some other medications. The first is leukotriene antagonists. And there are 3 medications that fall into this category. They have highly forgettable names and difficult to pronounce, but they are montelukast, zifurilocast, and xyluton. And the most common that you'll see in clinical practice is definitely montelukast, or singular. And the leukotriene antagonist works by decreasing mucus secretion in the airway and also decreasing bronchoconstriction by blocking the leukotriene pathway of inflammation in the lungs. They work in 2 different ways. The 2 drugs that end in KAST, montelukast and zifurilocast, they work by blocking the leukotriene receptor in the lung, and then the xyluton blocks, actually this a little bit higher up in the pathway, blocks the synthesis of the leukotriene. So they have a little bit different mechanism of action, but the same outcome. And important for you to know and to put to fill in your study guide are the possible adverse effects from leukotrienes, and that from all 3 medications can cause liver toxicity. The 2 that start with a Z, the xyluton and zifurilocast, they inhibit P450, so it's another one to add to that list of medications that inhibit P450 and may affect metabolism of other medications, like classically warfarin. And then also just to know, it's very uncommon, but potentially you could have adverse effect of eosinophilic vasculitis called Churg-Strauss that would show up after treatment with a leukotriene antagonist. The leukotriene antagonists are great medicines. They're very easy to use. They're oral. The montelukast comes in a chewable form, so it's very easy for patients to use. But again, I encourage you, don't use that in the place of an inhaled corticosteroid. The next medication for asthma is cromolyn. This is an inhaled medication. The mechanism of action is not well understood, but it is used to block the bronchoconstriction caused by allergic asthma and also exercise-induced asthma. It works very well for these problems. However, it has to be dosed 4 times a day, and it's very difficult for a patient to take any medication 4 times a day, and so noncompliance is a problem. The next class of medications are very commonly used for asthmatics in the hospital as opposed to at home, and that group are the cholinergic antagonists, the classic for that being ipratropium. And these medications block bronchoconstriction, and they're used in conjunction with your beta-2 agonist in asthmatics in an acute exacerbation of asthma. So what do I mean by that? I mean, if you have a patient coming into the emergency room who has asthma and who has suddenly developed difficulty breathing and is coughing and you hear a lot of wheeze, you're going to definitely give your beta-2 agonist, your albuterol, but you might also add in with that same treatment ipratropium to help with bronchodilation, or actually prevent bronchoconstriction. So you'll hear this on the wards a lot. The brand name for ipratropium is Atrovent, so you'll hear people talk about an albuterol Atrovent combo or an ANA neb, and that's what they're talking about. They're doing those as combined treatments. For asthmatics, that's typically in an office, ER, hospital setting, and not typically given at home as a bronchodilator. There are very few side effects from the cholinergic antagonists, and they're generally very well tolerated. The next medication I'd like to talk about is theophylline. This used to be very widely used, is not used so much anymore, but it again is a bronchodilator. It can be given orally. And what you need to really know about theophylline is that the challenge of using it is that it has a narrow therapeutic window. So I know you know what this means, but the dose that gets you not enough effect and the dose that's toxic are very close together. You're trying to find that dose right in the middle, and that can be very difficult. So you have to check theophylline levels, and there's wide differences in metabolism between different people. So children metabolize much faster than adults, who metabolize faster than infants and elderly. So it makes it a difficult medicine to use, and there's better choices available. So you won't see it used as widely, but you definitely should remember when you hear theophylline, you should think, oh, that has a very narrow therapeutic window. And then the last medication I'd like to talk about is another one of the tongue twister medications, omalizumab, and that ends in MAB, and that's telling you it's a monoclonal antibody. It binds IgE and prevents inflammatory response in the lungs. It works very, very well. It's very expensive. So you won't see it used very often, and it's reserved for very severe asthmatics, but you definitely should know the mechanism of action.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. Let's go through the answers to quick review 2. Question number 1. Complete the following table of alternative asthma therapy. Your leukotriene antagonists fall into 2 main categories. Xylutone, which inhibits, its action is to inhibit lip oxygenase, 5-lip oxygenase in order to be more specific. So xylutone inhibits 5-lip oxygenase. Zafirlukast and montelukast, they block the receptor, so they don't inhibit the enzyme, they block the receptor. And one way to remember this is your zafirlukast and montelukast inhibit the last step of your leukotriene pathway, which would be the leukotriene receptor. These drugs are all used to help improve asthma control. So they can be used in addition to your inhaled steroids, or in addition to your long-acting beta-2 agonists. They are not rescue medications by any means. Additionally, your montelukast is commonly given for allergic rhinitis, so it's FDA approved in the treatment of allergic rhinitis as well. Especially these drugs may be even more helpful in patients with aspirin-induced asthma, but in my practice, if patients they're either going to respond to these leukotriene antagonists or they're not. So you might give them a trial for a month. If it doesn't help them, these can be expensive drugs. Just go ahead and stop them. But in some patients, they do offer significant benefit. The adverse effects The main thing to know here is the xylitol can elevate hepatic enzymes. All right, so that might be a test question you might see somewhere. Xylitol elevates liver enzymes. Dr. Moore also mentioned the eosinophilic vasculitis called Churg-Strauss syndrome. Vasculitis, what is vasculitis? It's an itis, it's inflammation of the vasculature, so vasculitis. So it's an inflammatory disease of the vasculature, Churg-Strauss, just very basic introduction to that there. But montelukast in general, very safe, very well tolerated. Moving on, your mast cell stabilizers. So as Dr. Moore mentioned, these are not commonly used anymore because they have to be dosed so many times a day. 3 or 4 times a day you have to take these medications. What do? They stabilize mast cells. So they prevent the degranulation of mast cells. What do mast cells generate? They generate histamine, right? So less histamine means less inflammation. So you can see how that would improve asthma symptoms. Are these rescue medicines? No. They're more preventive medicines. They prevent asthma exacerbations. So asthma prophylaxis. Now one other thing, these drugs can also be used, they can be dosed intranasally in the treatment of allergic rhinitis as well. So cromolyn in particular is over the counter, and you can take that 3 times a day to help relieve your allergic rhinitis. Is it a rescue medicine? No, it's a prophylactic medicine. Adverse effect, again, these are pretty well tolerated. They can be a little bit bitter, they might irritate your throat a little bit, but pretty safe drugs. Moving on, your cholinergic antagonists, like ipratropium. So what these do is they block the vagally mediated contraction. So your vagus nerve, right, is a cholinergic nerve, your vagus nerve uses acetylcholine. Let's put it that way. So it makes sense that a cholinergic antagonist would block your vagus nerve, which uses acetylcholine. So it blocks the contraction of airway smooth muscles and mucus secretion. So you can see how that would be a benefit. Is this used as a rescue medication? Yes. Okay, ipratropium is commonly given with albuterol in the acute treatment of an asthma exacerbation. So that may be something worth noting. But you don't give it by itself, you give it with albuterol or levalbuterol. In some patients, ipratropium can be given long-term, more regularly scheduled dosing. In particular, COPD patients are more likely to be using ipratropium. So usually when we think about ipratropium, acute rescue treatment for asthma along with albuterol, or given on a daily basis a couple times a day for the treatment of COPD is the common way that you're going to see ipratropium being used. Adverse effects, there's really not a whole lot of adverse effects with these guys. Methylxanthines like theophylline, these are bronchodilators also. They can be used to treat asthma. They can also be used to treat COPD. These are more like 3rd or 4th line drugs. If nothing else is working for your asthma, or if nothing else is working for your COPD, you might reach for theophylline. Why? Again, it has a very narrow therapeutic index. It can be dangerous. In particular, what can it cause? 2 main things I want you to know for theophylline overdose. Highly testable. Seizures and tachyarrhythmias. All right, so seizures and tachycardia. How would you treat a tachycardia due to theophylline? You would give a beta blocker. All right, we'll talk more about that in a little bit. And the last one, omalizumab. It's a recombinant monoclonal antibody. So it's an antibody that binds to IgE, and IgE is an important mediator in allergies and asthma. So by doing so, it's going to decrease the release of your allergic response mediators. It can be used for moderate to severe asthma, but it's not commonly used. It's very expensive. Number 2, what medications are used in the treatment of acute asthma exacerbation? Patient comes into the ER, acute asthma attack. What are you going to reach for first? You're going to give an oral or IV steroid. Commonly, you might give a methylprednisolone or prednisone. And additionally, you're going to give 3 rounds of albuterol with ipratropium, the combination of those 2. And then after that, after the 3 rounds of albuterol with ipratropium, if needed, you give more albuterol. All right. But what if their oxygen saturation is very low? You give oxygen also. So now we have 3 things: steroids. 4 things: steroids, albuterol, ipratropium, oxygen as needed to raise your oxygen levels. Patients have to have oxygen, right? It's your ABCs: airway, breathing, circulation, If their pulse ox is very low, they're not getting enough oxygen, you got to give it. If that means you have to intubate the patient, then by all means intubate the patient, give them some oxygen. So that's the quick way. Alternatively, if none of that has worked, you might try inhaled epinephrine as an alternative. In some ERs, they give magnesium in order to relax smooth muscle. Dosing IV magnesium can relax smooth muscles, and it can help treat asthma. Not real common, definitely not first line, but it can be done. That's all I have for you right now. I think we may have one other question though.
What two conditions do we treat with leukotriene inhibitors such as montelukast? Asthma and allergic rhinitis. How is it possible that you haven't flunked out yet? You are beyond hopeless. You bring down the IQ in here so far that I may be getting stupider just by being around you.
Now we'll move on to COPD. You know all the medications for COPD already because we've just talked about them for asthma, but I'll talk about the differences between asthma and COPD and their usages. COPD is chronic obstructive pulmonary disease, and unfortunately, unlike asthma, COPD is progressive. So patients can't expect to have patients can expect to have progression of their symptoms over time. And so our treatments really focus on decreasing their symptoms and then treating their exacerbations of their COPD when those occur. When you hear COPD, you probably think smoker, and that's what I want you to think. This is a disease certainly that affects a lot of smokers. About 80% of people with COPD have been or are smokers, and so certainly you want to encourage them to stop smoking. Not always possible. Unfortunately, the addictive properties of nicotine can outweigh your good advice and your patient's really common sense. So it's not an unusual sight to walk into a hospital and see patients sitting out front smoking a cigarette with their oxygen tank next to them. Unfortunately, it's a fact of clinical life, but you can try, and you can ask again and wait till the time when they're ready to quit. When we talk about classification of COPD, it's really divided into 3: mild, moderate, and severe COPD. For the mild patients with mild COPD, you're going to treat that with bronchodilators, the beta-2 agonists, and in COPD, often you'll use a daily dose of the cholinergic antagonists like ipratropium or its long-acting version, tiotropium. As we move into moderate and severe COPD, one thing you should know is that at the moderate level, we'll add in inhaled corticosteroids for symptom relief. Unfortunately, it's not going to stop the progression of the COPD. And then this is in your study guide. This is a question in your study guide as well, but the difference in treatment between moderate and severe COPD is that those patients will often need oxygen therapy, and then they may need antibiotic therapy during exacerbations. COPD patients are much more likely to have a bacterial infection in their lungs when they have an exacerbation as compared to an asthmatic, who most of the time they don't have an infection other than viral respiratory infections.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. All right, let's review your study guide questions. Number 1, what is COPD? It's chronic obstructive pulmonary disease. There's 2 main diseases that are categorized as COPD. There's chronic bronchitis and there's emphysema. So emphysema is COPD. Chronic bronchitis is COPD. What's your biggest risk factor for COPD? Smoking, right? So those are some things, just some generalities about COPD. Number 2, how does the stage of COPD determine the treatment? So just like there's different degrees of severity for asthma, there's different stages of COPD. And in any respectable text, before you get stage 1, you have risk factors for COPD, such as smoking. So in smokers, how do we treat smokers to help prevent COPD later on? Of course, you want to counsel for smoking cessation. Additionally, these patients should receive influenza vaccine. And so what we're going to see as we go from one stage to the next, you're always going to incorporate the treatment from the previous stage. So for stage 1, stage 2, stage 3, again, it's also smoking cessation, annual flu vaccine. Anyway, but moving on, stage 1, mild disease, where you have a pretty decent FEV1, but you're showing some signs of disease because your FEV1 to FVC ratio is less than 70%. You're going to have a short-acting bronchodilator. So you prescribe the patient some albuterol to use as needed. One other thing I did want to mention about COPD, we talked about how asthma is reversible. COPD is not reversible. So there's not intermittent COPD. You either have COPD or you don't. Stage 2 COPD, which is moderate COPD. So again, everything above, smoking cessation, influenza shot, short-acting bronchodilator like albuterol to use as needed, but now you're also going to add in a long-acting bronchodilator. And long-acting bronchodilators for COPD come in two varieties, either the long-acting beta-2 agonist like salmeterol, or you can use an anticholinergic like tiotropium. Stage 3, again, everything above. Now you're going to add in inhaled steroids for stage 3. And what if none of this stuff is working? What's the drug that we said earlier would be sort of fourth line if your traditional protocols are not working? You might consider theophylline if none of this stuff is working. For acute exacerbations, you might need antibiotics to treat acute exacerbations. You might need systemic steroids for a couple weeks. And you also might need oxygen if the patient is having a hard time oxygenating. Number 3, what is the general rule for when a COPD patient requires home oxygen? When the arterial O2, or when the pulse ox, I should say, when the pulse ox is less than 88%, and as a general rule, these patients are now qualified to receive oxygen at home. So those patients that you see walking around in the community with oxygen on them probably have COPD because of their smoking, and without the oxygen, their pulse oximeter, which is a measure of the oxygen saturation at their tissues, is less than 88%, which is not good. Number 4, table of drugs used to treat COPD. So again, you have your inhaled anticholinergics, ipratropium, which is Atrovent, and tiotropium, which is Spiriva. Your beta-2 agonist, your short-acting rescue agent is albuterol, your long-acting is salmeterol. So we talked about your beta-2 agonist earlier. Let's talk about your inhaled anticholinergics. Again, actually we did mention this earlier as well. So they block the vagus nerve contraction. They block smooth muscle contraction of the airways, which is mediated by the vagus nerve. So it prevents that from taking place. Therapeutic use, we just talked about the different stages of asthma when you would need to, or stages of COPD where you would need to incorporate these drugs. So really nothing new on this table that we haven't already discussed with asthma. Number 5, what are the side effects of theophylline overdose? The two main things we mentioned earlier were tachyarrhythmias and seizures. All right, so for tachyarrhythmias, what's a drug of choice for treatment? You're going to use a beta blocker like propranolol. Beta blocker like propranolol to treat your tachycardia, tachyarrhythmia, and theophylline overdose. What if you have seizures? How are you going to treat the seizures with theophylline overdose? With a benzo, like diazepam, lorazepam, something like that. So that's a short version, but it is testable to know that. So let's move on to the next topic, which is allergic rhinitis.
This is a topic I'm sure many of you are actually very familiar with personally. It's very, very common, particularly depending on the area of the country you live in. But the diagnosis of allergic rhinitis, you're looking for the most common symptoms: runny or congested nose, itchy nose, inflammation and sneezing in the nose. And there are quite a few over-the-counter medications to treat this. So many of your patients will actually have already tried several different treatments that were over the counter before they come to see you. So we'll talk about those over-the-counter medicines so you're aware of them, and often you'll recommend them, and then also the prescription medications. All right, so the first treatment for allergic rhinitis are antihistamines. So these are the H1 histamine blockers. these come in two different forms over the counter. You have what are typically called your first generation medications. So this is like diphenhydramine or chlorpheniramine. They are oral medications that help with the symptoms of allergic rhinitis. They dry up the nose, they decrease the sneezing and itching. They also have a lot of systemic side effects. So these are anticholinergic side effects. So they'll experience sleepiness, dry mouth, decreased urination, or constipation, potentially from those medications. There are second generation antihistamines that are also available over the counter. That's loratadine and fexofenadine, and those medications have fewer of the side effects and also can be dosed once a day. So many times your patients will have already tried those medications before they come to see you. One other over-the-counter medication group that you should know about are the alpha adrenergic agents. These are typically described as nasal decongestants on packaging, and particularly these are very effective as a nasal spray. The way they work is they cause vasoconstriction, so the tiny vessels in the nose are constricted, and so there's decreased edema in the nasal passages and symptom relief from that. Very important for you to know to warn your patients about, and you should definitely write this on your study guide, is that anyone who's using these medications as a nasal spray, if they use them for longer than 2 or 3 days, they can experience rebound when they stop. What I mean by that is if they use these medications and they'll get good relief from them for 5-7 days and then they suddenly stop it, the body overcompensates and suddenly they're flooded with nasal secretion. So the bottles will say, and you should warn your patients, that they really shouldn't use those medications, the alpha adrenergic nasal sprays, for longer than 2 or 3 days. And I promised that there's overlap between asthma and allergic rhinitis, and that comes in the form of corticosteroid sprays. So as with the asthmatic and the patient with allergic rhinitis, you can use steroid nasal sprays to decrease inflammation. Unfortunately, it takes a week or 2 weeks for these to really take effect, and so often I'll have my patients start the steroid nasal spray and use some of the over-the-counter medications to kind of hold them over until the steroid takes effect. And the most common side effects from the inhaled nasal spray corticosteroid is nasal dryness. Some patients will actually develop problems with nosebleeds because of that, and they also can sometimes complain of a bad taste in their mouth. And the bad taste in their mouth can be avoided by reminding them that you want that medication in their nose, so they can spray it in their nose, but they don't have to try to inhale the world through the nose afterwards. They don't have to do that big sniff where all the medication goes from in the nose where it's going to work into the back of the mouth where they're just going to taste it. So if you warn your patients ahead of time, a lot of times you can avoid that complaint of the bad taste. And then the last treatment for allergic rhinitis that I want to mention is cromolyn. So also, as with asthma, this can decrease the nasal reaction to irritants and allergens and can be very, very effective with that. A couple of other treatments for allergic rhinitis that I want you to be aware of are leukotriene antagonists. So just like we used in treatment of asthma, these will block the leukotriene pathway and decrease inflammation. These are used in a nasal spray form, and also antihistamine sprays can be used to decrease the symptoms of allergic rhinitis. I want to take a few minutes to discuss the common symptom of cough, which actually you're going to have patients continuously asking you for cough medicines. They want to treat the cough. A cough is a very irritating symptom of many different diseases, and so your job as the physician is to figure out why they're coughing, because that may help you choose a completely different path than a cough medicine. So, certainly cough can be caused by cold viruses, sinus infections, pneumonia, influenza, but it can also be caused by gastroesophageal reflux, an irritation of the top of the airway from acidic reflux, and so that may be what's triggering their cough. And all the cough medicine in the world is not going to solve that problem. And then also a reminder for your asthmatics, they need to be thinking about using their rescue inhaler, the beta-2 agonist rescue inhaler, instead of a cough medicine. But if you have a patient that you're seeing and you think, oh, they've got a cold, they're very uncomfortable, they want some cough relief, there's definitely some choices for them. And I'm going to talk about a few of the main categories of cough medications. The kind of gold standard classic cough medicine is codeine. And this is a prescription medicine, and what it does is it decreases the sensitivity in the cough center in the medulla to cough. So your lungs have a lot of mucus in them. They're sending signals to the brain that say, cough, get this mucus out, cough, cough. And the codeine works by kind of blocking those signals and making it so that you don't cough as much. Codeine's a great medication. It does have some significant side effects. It can definitely cause sleepiness, and it can cause constipation, and then there is a risk for dependence to codeine. Another good choice that's over the counter is dextromethorphan. So these are all the DM medicines that your mom gave you when you were a kid and you were coughing. Dextromethorphan is a great cough medicine. It works similarly to codeine. It affects the cough center in the medulla, but it doesn't have the risk of dependence like you get with codeine, and it is also available over the counter. It works very well as a cough suppressant. One thing you need to be aware of is in the over-the-counter medications, it can be paired with a lot of other cough medicines. So if you went to a pharmacy today and looked at their just row after row of cough medicines, you're going to see that there's a lot of different options available. I advise my patients to use the syrups and cough medicines that only have the dextromethorphan, but you will often see the DM medicine paired with guaifenesin. Guaifenesin is a mucolytic. You'll see lots of advertisements for this for like a medication like Mucinex. Guaifenesin loosens up and breaks up the mucus. Dextromethorphan is often also combined with different antihistamines or nasal decongestants. And usually the more descriptors on the package, cough, cold, sneezing, it's going to have 2 or 3 medications in it. If it just says cough, it's more likely to just have 1 medication in it. And certainly appreciating how cough can influence people's quality of life is important, and I definitely use cough medicines frequently for symptom relief in my patients with sinus infections, pneumonias, that sort of thing. You just need to think about it and be cautious.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. Quick review 4. Number 1, completing the table. Your antihistamines are broken up into first generation and second generation. Your first generation, like diphenhydramine, like Benadryl, chlorpheniramine, brompheniramine, clemastine. These are all first generation. They're very sedating. All these drugs are sedating as an adverse effect. Additionally, all these drugs have antimuscarinic side effects. So these are what distinguishes first generation from second generation. More sedation, more antimuscarinic side effects. What is antimuscarinic side effects? Antimuscarinic side effects is anticholinergic side effects. And you might remember these as side effects like dry as a bone. You have decreased secretions, which is good in the treatment of allergic rhinitis, right? Hot as a hair, you can have increased temperature. Mad as a hatter. An elderly patient, if you give them a first generation antihistamine, because of the anticholinergic side effect, you might put them into delirium. Your first generation antihistamines are a common cause of delirium in elderly or demented patients. Another anticholinergic side effect that you might see with these drugs is bloated as a toad. You're going to have constipation and urinary retention. So if you have a patient with maybe BPH, swelling of the prostate, they're having a hard time getting urine out, those symptoms might worsen with first-generation antihistamines. Whether first generation or second generation, the action is the same. It's inhibition of the H1 histamine receptor. Okay, we distinguish the H1 histamine receptor from the H2 histamine receptor because the H2 histamine receptor is involved in gastric acid production. So H2 antagonists help relieve gastric acid secretion in excess. These drugs are antihistamines at the H1 receptor. So therapeutic use of your first-generation antihistamines in general, used for allergies. There are other first-generation antihistamines that can be used for other reasons. Sometimes patients will take first-generation antihistamines to help them go to sleep. Some unique first-generation antihistamines can be used to help relieve symptoms of nausea and vomiting or motion sickness. But so those are those. Your second-generation antihistamines, in general, they're primarily used for allergies. This is loratadine, desloratadine, fexofenadine, and cetirizine. And their adverse effect, the main thing to know is that they're far less sedating than the first generation. But looking at these 4 second-generation antihistamines, which of those 4 is the most sedating? It's actually the cetirizine. So if you have a patient that is too sedated on cetirizine but still wants to be on a second generation, they can choose one of the other 3 second-generation antihistamines. Your alpha-adrenergic agonists are broken up into 2 categories, the ones given intranasally, like phenylephrine, and oxymetazoline, and the ones that are given systemically, like pseudoephedrine and phenylephrine. So this is like Sudafed. So the way these drugs work with allergic rhinitis, you have dilated arterioles in the nasal passageways. And so when you have dilated arterioles, you have increased vascular permeability, very leaky vessels that augments the generation of more mucus. And so these drugs, they clamp down vessels. All right, so they take your arterioles and they prevent them from being so dilated. So they clamp them down, and as a result, you have vasoconstriction. All right, so these drugs for therapeutic use are actually very helpful in the treatment of nosebleeds. What's the medical term for nosebleed? Epistaxis. So if you have a patient with nosebleeds, you might try an intranasal alpha-adrenergic agonist like phenylephrine or oxymetazoline involved in the treatment. The downside of the intranasal drugs is that they can they're great for about 3 days, but then longer than 3 days, your arterioles in your nose become addicted to them. And so that when you take them away, they're used to, they obtain a new normal with that drug on board. And when you take the drug away, boom, you have a rebound dilation of those arterioles again, and then more congestion. So patients can become addicted to these drugs so that when they go off of the drugs, they have lots of nasal congestion that forces them to go back on the drugs. So it can be a vicious cycle. So the rebound congestion is one of the adverse effects. Other than that, they're pretty decent drugs. Now your systemic alpha-adrenergic agonists, they're clamping down vessels. What do you think that would do to blood pressure? It's going to raise blood pressure. So you have to use caution in patients with hypertension when you're giving them a systemic alpha-adrenergic agonist. Additionally, you can have some dizziness and palpitations. When you take cough and cold medicine and you get that sort of woozy, dizzy feeling, it's because of the antihistamine, and it's because probably of the alpha-adrenergic agonists, like pseudoephedrine or phenylephrine. All right, intranasal corticosteroids, we've talked about those corticosteroids already when we talked about inhaled corticosteroids. For the adverse effects here with the intranasal corticosteroids, just want to mention that you can have nasal dryness as a result of these. So particularly in winter months, patients on intranasal corticosteroids are more likely to have epistaxis, which is nosebleeds, right? So just something to be aware of. Mast cell stabilizers like cromolyn can be given intranasally. We said that was over the counter. The downside here is it has to be dosed several times a day, right? Number 2, why should intranasal alpha-adrenergic agonists not be used long term? Again, the risk of rebound nasal congestion. Your nose, your arterioles in your nose become addicted to it. Number 3, which patient populations in particular should use caution when taking systemic alpha-adrenergic agonists? Hypertensive patients. It doesn't say it's contraindicated. It says these patients need to use caution. So they need to monitor their blood pressure more closely if they're going to be on these drugs. And some patients shouldn't be on these drugs if their blood pressure is not well controlled. Number 4, why should first-generation antihistamines not be used in the elderly? Again, that anticholinergic side effect, mad as a hatter. It's one of the most common drug categories causing delirium in elderly patients is the first-generation antihistamines like diphenhydramine. Number 5, what should be used to relieve nasal secretions in infants? So you don't use any of these drugs in infants. What you do use is saline drops and bulb syringe. So kind of a trick question, but infants, particularly if they're younger than 1 year of age, the best thing to do to relieve nasal congestion, put some saline drops in their nose and suck out the congestion with the bulb on a very regular basis. The next one, cough. What are some of those common causes of cough? The reason why this question is in here, when you're treating cough, you don't just reach for symptomatic treatment of the cough. You figure out why the cough is there in the first place, and you treat the reason why the cough is there. So the 4 most common causes of cough are GERD, gastroesophageal reflux disease, postnasal drip from things like allergic rhinitis, asthma. We said the classic symptom of asthma is cough, and then bronchitis also. So search for those things. There's a ton of other things that can cause cough. Of course, pneumonia causes cough, smoking can cause cough, but if you have a patient with chronic cough, you might talk to them about GERD symptoms because in those cases, the treatment wouldn't be an antitussive. The treatment would be something to reduce stomach acid to relieve the symptoms of their GERD and prevent the laryngeal irritation from the GERD, the gastroesophageal reflux disease. Number 7, table of drugs used to treat cough. Your antitussives are either non-narcotics or narcotics. These are all opioid-like drugs. And they are going to suppress the medullary cough center. So they're going to suppress the cough reflex in the medulla. And so there's carbetapentine, and there's carbetapentane. There's dextromethorphan, which is drugs that have DM at the end of them. So these are over-the-counter drugs. Antitussive narcotics, pretty much any opioid will relieve cough. So if you have a patient on morphine, that's going to relieve their symptoms of cough. But obviously, morphine is not the drug of choice to relieve cough, right? But codeine is. So anything with AC in it has codeine in it. And these are prescription, of course. Hydrocodone can help relieve cough. So lots of different drug combinations have been created to relieve these symptoms. In general, they're combinations of antitussives with other things like antihistamines or mucolytics. So therapeutic use, antitussives are used for cough. Adverse effects, these are your non-narcotics really don't have a lot of adverse effects, but your narcotics do. Of course, you can have narcotics can cause constipation. Narcotics can cause pupillary dilation, which is pupillary constriction, which is meiosis. Narcotics can cause sleepiness and fatigue. They can cause addiction. So if you're going to give, a cough, you have to be careful when you prescribe cough medication that's prescription cough medicine because you'll have drug-seeking patients just looking for that prescription to get their hands on some codeine. Doesn't mean you shouldn't prescribe it. Again, just exercise caution. Your mucolytics, so they loosen up mucus to help you expectorate sputum. So sometimes mucolytics are called expectorants. Guaifenesin actually increases secretions, and by increasing secretions, it actually makes your secretions more fluid. So if you have very thick secretions, it'll make more fluid secretions that are easier to get up. So the reason why guaifenesin commonly is mixed with antitussives, like dextromethorphan, is you want to get up secretions. You want to get things out of your lungs, right? But you don't want to be coughing for no reason. So the antitussive is not going to completely suppress your cough reflex. It's just going to suppress it a little bit. But when you have something that really needs to come up, the guaifenesin is going to help loosen that up so that it can come up. Therapeutic use, it's going to increase sputum production, loosen up sputum so you can get rid of it. But again, it's not going to cough. It's not going to suppress the cough reflex, so you might have to combine it with an antitussive. Adverse effect, in general, these are pretty well tolerated, safe in pretty much any patient, adult patient that is. Other mucolytics include acetylcysteine or N-acetylcysteine. This is a drug that is inhaled. A lot of times this is given to intubated patients who have lots of mucus. This can be given to cystic fibrosis patients to help relieve their mucus plugs. And it's pretty well tolerated as well.
Okay, so now's a good time to pause the video and complete your in-session quiz. Then restart the video and we'll go through the quiz together.
All right, let's go ahead and go through the answers on your in-session quiz. The first question, fill in the blanks in the table about which agents are used for long-term control of asthma. Now really, I think the first thing to do is to go back and review the classification of asthma and then fill in the table. So everyone needs a short-acting beta-2 rescue inhaler. So that's our rescue inhaler of albuterol. But now we're talking about persistent asthma, so we need to add some daily medicine to take on a routine basis, and we're going to add a low-dose inhaled corticosteroid. All right, the next one is moderate persistent asthma. And again, everyone needs a short-acting beta-2 inhaler. Then we're also going to increase the inhaled corticosteroid to a medium dose, or you can continue the low-dose inhaled corticosteroid and add a long-acting beta-2 agonist, such as salmeterol. Now, one way you can remember that salmeterol is a long-acting beta-2 agonist is you look at the word salmeterol and you think of salmon. Well, salmon have to swim upstream in order to mate, and it takes a long time to get there. So you can remember that salmeterol looks like salmon. It takes a long time to get there. It's a long-acting beta-2 agonist. And then finally, for severe persistent asthma, you want to use your short-acting beta-2 rescue inhaler. You're going to use a high-dose or a medium-dose corticosteroid as needed, and you're definitely going to add the long-acting beta-2 agonist such as salmeterol. So for the next question, what are the side effects for the following medications? For montelukast, you can get elevation in hepatic enzymes. You can get eosinophilic vasculitis, which is also known as Churg-Strauss syndrome. This is pretty rare. You can get headaches, and you can get dyspepsia, or GI upset. For cromolyn, there are not many adverse effects. You can get some throat irritation and some bad taste in the mouth. For diphenhydramine, the main one for any antihistamine is sedation, especially these first-generation antihistamines. Sedation is a big side effect. You can also get antimuscarinic or anticholinergic side effects. Remember these: hot as a hair, dry as a bone, bloated as a toad, etc. And the side effects of albuterol, you can get tachycardia, you can get hyperglycemia, hypokalemia. Remember that albuterol is sometimes used in emergencies to treat hyperkalemia. So if you give albuterol to someone with normal potassium levels, they can get hypokalemic, and you can also get hypomagnesemia. And the adverse effects of albuterol are minimized with the inhalational route as opposed to the oral route. All right, the next question. What medication would you use to treat the following patients? So the first one is a 9-year-old girl with mild intermittent asthma who needs quick relief. Well, remember, mild intermittent asthma, all she really needs is a rescue inhaler, that short-acting beta-2 agonist, so that's albuterol. The next one, a 72-year-old man with COPD who needs daily controller medication. You want to use ipratropium or tiotropium, one of the antimuscarinic agents, plus or minus an inhaled beta-2 agonist, such as albuterol or salmeterol. All right, the next one, a 34-year-old woman with severe persistent asthma is having side effects to her corticosteroids and needs an adjunct therapy to help reduce her dose. So severe persistent asthma, she should be on a long-acting beta agonist such as salmeterol, and she should be on high-dose steroids. Steroids are the mainstay of treatment for persistent asthma, but sometimes patients just can't tolerate them. So if you have to reduce the dose of steroids, you want to continue the long-acting beta agonist, continue that salmeterol, and then consider adding something like leukotriene antagonist, such as montelukast or zovherculast. And then the last one, a 28-year-old man has a bad cough associated with an upper respiratory infection. So what kind of drug are we looking for? A cough suppressant. You can use dextromethorphan. If they have a really severe cough, you may want to give codeine short term, but that has some problems with addiction and dependence. All right, the next question. Match the agents below with the respiratory condition that they're used to treat. So I'm going to start with the opiates and work my way across. So the opiates are used to treat cough. Cromolyn is used to treat asthma and also sometimes allergic rhinitis. The beta-2 agonists can be used in the treatment of asthma and also COPD. Antihistamines are used to treat allergic rhinitis. Ipratropium is used to treat COPD and sometimes asthma. The alpha-adrenergic agents are used to treat allergic rhinitis. Theophylline is used to treat asthma. Zafirculast is used to treat asthma. Corticosteroids can be used to treat asthma or COPD, and then also nasal corticosteroids are used to treat allergic rhinitis. And then finally, omalizumab is one of the anti-IgE monoclonal antibodies, and that's used to treat asthma. Next question, what is the mechanism of action of the following medications? All right, so for cromolyn, this drug is going to prevent the release of mast cell mediators. Ipratropium is an anticholinergic drug. It blocks the vaguely mediated bronchoconstriction and mucus secretion. Salmeterol is a selective beta-2 agonist that's long-acting, as we said. It's a potent bronchodilator that relaxes airway smooth muscle. Terbutaline is another selective beta-2 agonist and a potent bronchodilator. Guaifenesin is a mucolytic. It reduces the viscosity of sputum. It's available over the counter as Robitussin or Mucinex. Desloratadine is an antihistamine. It's a reversible inhibitor of the H1 histamine receptors. And the last one is prednisone. It's a glucocorticoid. It inhibits the synthesis of cytokines and decreases the production of TNF-alpha and other inflammatory mediators. All right, next question. What are the side effects of theophylline overdose? Theophylline overdose can cause a lot of different effects. It causes tachycardia, and therefore it causes some hypotension. It often causes seizures. It can lead to agitation and anxiety. It can lead to nausea and vomiting. And it can cause hypokalemia and hyperglycemia. So how do we treat theophylline overdose? Well, the current treatment recommendations can include one or more of the following. A fluid bolus with isotonic fluids such as normal saline. You give an antiemetic agent to control vomiting, maybe metoclopramide, maybe ondansetron. You can give propranolol to reduce heart rate, although you don't want to give propranolol to someone with asthma because that can trigger bronchoconstriction, so maybe you give another beta blocker that's a little safer. You can give a benzodiazepine to reduce anxiety and to decrease the risk of seizures. You can use phenylephrine or norepinephrine to increase the blood pressure if needed. And as a last resort, rarely we use charcoal hemoperfusion. This is where you pass the patient's blood through a charcoal filter and remove the theophylline from the circulation. Next question, what medications are used to treat moderate COPD? Well, patients with moderate COPD need routine daily treatment. They don't need just as needed treatment. They don't need a rescue inhaler. They need regular treatment on a daily basis. So you want to use at least one bronchodilator. This could be a beta-2 agonist, a long-acting beta-2 agonist such as salmeterol, or a short-acting beta-2 agonist such as albuterol. And then you may also want to use an anticholinergic such as ipratropium and tiotropium. And then you also want to use an inhaled glucocorticoid, an inhaled corticosteroid for the treatment of moderate COPD. Next question. What inhaled mucolytic is often used in cystic fibrosis patients? Well, the mucolytic that they often use is called N-acetylcysteine, or the brand name you may hear is Mucomyst. Next question. What are the side effects of the beta-2 agonists? Well, beta-2 agonists can cause a lot of side effects that you need to be aware of, including tachycardia, hyperglycemia, hypokalemia, and hypomagnesemia. And remember that these side effects are minimized when you use an inhaled beta-2 agonist. The next question, which beta-2 agonist is least likely to cause tachycardia? Well, the answer is levalbuterol. The brand name is Xopenex. It's more potent than albuterol, so you can get equal bronchodilation with lower doses. And when you have a lower dose of a drug, you generally have fewer adverse effects. And that's the end of your end of session quiz.